afternoon. Welcome back. I'm Mabel Jong, and you're watching continuing coverage of the World Healthcare Congress here in Washington, D.C. I'm so pleased to have Heidi Cottle here. She is with the National Financial Partners Corporation and Corporate Services, and she's going to be talking about some of the things that she's seeing in the healthcare sector, and if modified, how that would change the landscape. Heidi, thank you so much for your time today.
Oh, thank you for letting me be here.
Well, I gave you a nice lead-in.
You
What are
did.
some of the things that you think could really alter the landscape of healthcare?
I appreciate that. You know, Mabel, I don't want to diminish the complexity of healthcare and all of the challenges within not only the healthcare delivery side, but within the health insurance side. But as I have looked back at my 31 years, there is some real key components of healthcare. I recently experienced a house fire, and I've realized how important the foundation, not only of a home is, but of a building or healthcare. And so as we take a look and collapse the industry and look at what has happened to primary care, it has become dysfunctional. When you look at the stats which really support what's happening, what type of care can be rendered within 7 to 10 minutes in a primary care physician's office? So as we've taken a look at the dynamics of healthcare and really focused on the foundation of healthcare, we've come up with some really pretty simple solutions. Now, the application of those are a little bit more challenging, but when you take a look at the third-party payer system, and what has created the dysfunction in healthcare, currently primary care doctors are having to see 3,000 to 4,000 patients, have a base of that, which is actually 30 to 40 patients a day. That's where you back into the 7 to 10 minutes. So what type of care can really be rendered in that environment? Unintended consequences are essentially that they're referring out to specialists more frequently. They're prescribing drugs more frequently. We are seeing, a lot of misdiagnosis, and all of those things contribute to rising healthcare costs. So in our perspective, if you basically collapse it down and build it back up, and that meaning that you eliminate all of the third-party payer payment side and reducing the administrative costs, what ends up happening is now the doctor, rather than spending 7 to 10 minutes with the patient, can now spend 30 to 40 to 45 minutes with that patient. It reduces their patient base to 700 to 900. So let me kind of explain some of the dynamics there. So when you take a look at the access to care, the affordability of care, and quality of care. So access, what we have found in the employer workplace, they have 4 different generations in the workplace. This is the first time in known stats that we have 4 generations. So we have not only the silent generation, we have the baby boomers, we have the X and Y generation, and each one of them understands healthcare very differently. So how do we focus on getting the right care to them? Well, the millennials, they have no idea what a primary care doctor is. So where do they access care? They go to convenient care centers, they go to urgent care centers, they go to emergency rooms for their care, which is anywhere between 50% higher cost or up to 1,500% higher cost, and it's still primary care. Where you look at the silent generation and the baby boomers, and we're used to a primary care doctor, and I basically will age myself here, but I remember when my primary care doc came to my home. So what has happened? We've broken that relationship with the doctor and the patient, and we need to put that back again. And the best way to do that is in a fixed cost environment where you eliminate the administrative costs, you can increase pay to the primary care doctor, and you begin to start seeing true care being expended, and we stop backfilling chronic conditions.
Well, let me ask you, what sort of discussions do you have at National Financial Partners Corporation? How are you a player in this area?
Absolutely. So NFP several years ago was a publicly traded company and decided to go privately held. And so doing, we have become much greater at our innovation. And we are the 5th largest privately held brokerage consulting, not only domestically but internationally. And we have a footprint of about 148 different offices throughout the country. So our innovation is actually driven up rather than corporate driven down. And our CEO has often said the greatest challenge he has on a daily basis is managing the entrepreneur. So these are the discussions that we're having. How do we truly impact the cost of care and bring access, affordability, and quality back? And when we look at primary care as the foundation to that, if we don't correct the foundation, it's going to be very difficult to affect the efficiency of anything above it.
Now, is part of the foundation perhaps addressing regulatory or policy issues that might impede progress in improving what we have now?
Absolutely, absolutely. So if you take a look at right now, some of the regulatory issues and some of the policy issues, not only on a state basis, but on a national basis. Direct primary care is really now coming in as an innovative solution, and not just for, the jumbo employers. Okay, so the jumbo employers, when you look at the SBA, again, as they do their statistics every year, 99.7% of employers in the United States are below 500 employees. And yet, a lot of the employers that are driving policy, which again, their level of influence is greater, are the Fortune 50, Fortune 100, Fortune 1000 companies. So when we're looking at developing solutions, a lot of those regulations need to be modified or eased in a couple of areas. And let me be specific, if I may, to a couple of those areas. The one being direct primary care. We have been working with different lobbying groups to be able to influence that direct primary care, which is truly not insurance, be carved out of the definition. Now, some states have already done that, but on a federal level, that would help us with being able to get quicker adoption and being able to offer direct primary care to smaller employers, which in larger employers it may be an on-site clinic. Well, we're doing nearby clinics so that multiple employers that, as aggregators are able to come in and then participate in those type of cost savings to bring access and affordability and quality. So that's a positive. The other piece is, which I'm a high proponent of, qualified high deductible health plans. But within the legislation of qualified high deductible health plans, one of the unintended consequences was that we've really, yes, empowering, I think, of the consumer is critical. But there's a fine line between empowering the consumer and empowering them where they feel that they have to diagnose themselves and go out and Google and go out to WebMD and say, okay, I know I now have these conditions. They go in to see their current primary care physician in the 7 to 10 minutes and say, okay, I know I have this, and can you prescribe me this? And the doctor doesn't have any time to re-educate that person. So in being able to, under an HSA environment, eliminate that first dollar coverage for types of preventive care type services that are being really provided in this new delivery of care model, which is direct primary care.
Okay. Yes.
And that is key, because then they can go in, and so let me talk about the quick financial model of it. It still is embedded as a narrow network within a health plan. Okay, so the employee still has the option of going to their own primary care doctor. It's not a gatekeeper environment. But when you go to those doctors, it's a $0 copay. So the individual is just paying for like a membership on a monthly basis to get access to it. But a lot of those plans we embed in the total cost of care. So they're able to use that rather than going to a convenient care center or an urgent care or a steerable emergency room visit. So they're able to access that care, and we can start putting that doctor back with the patient, so they can start, the doctor can really start educating them as to what the best treatment of care can be.
Okay. Well, Heidi, it's certainly a great analysis. We really appreciate your time and sharing them with me today.
Thank you.
And I've just been speaking with Heidi Cottle of NFP. Stay tuned. We have many more interviews to share with you. I'm Mabel Jong. Thanks for watching.